So once again, welcome to the 17th session of this International IVF Initiative, or I3. And I am honored and excited to be introducing this session that was funded by Dr. Jacques Cohen and Thomas Elliott only a few weeks ago, but it has reached enormous success by reaching out to thousands of fellow colleagues from over 80 different countries. I'm also honored to be regarded as a friend of Jacques, whom I know for a very long time and I consider as my mentor. I'm also honored working with Thomas. He's actually a colleague of mine here at RBA, who is not only a gifted embryologist, but also an internet and a Zoom genius. My name is Peter Nagy. I'm an embryologist working at the Reproductive Biology Associates, Atlanta, Georgia, in the United States. And I'm excited to introduce to you today the session entitled this roundtable discussion. And my co-host and co-moderator is Dr. Kelk, and she is the director of IVF laboratory at Yale's Fertility Center and associate research scientist at the Yale University of Medical School since 2014. Dr. Kelk, clinical and research interests are diverse, ranging from trophectoderm biopsy, PGT, vitrification of embryos and oocytes, analysis of liquid nitrogen, cryo storage tank failure, and the laser impact on embryos and predictors of endometrial receptivity. Dawn today has a dual role. She's working as a moderator, but she's also a roundtable panelist. We have a really great program for you today involving 6 well-known embryologists from all different parts of the world. There is one from the US West Coast that I'm sure it's ready to have a lunch soon. And we have some from the East Coast. We have one panelist from the United Kingdom and one from Europe, Spain. Probably both of them would be happy to have a dinner soon. And one from New Zealand, who just took his first coffee in the morning. By the way, for him, it is already Wednesday, not Tuesday. So that means that he's ahead of us. He's always ahead of us. So this webinar is structured differently than the previous webinars. This is a roundtable discussion where attendees can ask any and all panelists questions on various topics of embryology and IVF laboratory. To give time to the attendees to write questions in the first 20 minutes, each panelist will review briefly a topic, after what the moderators start asking questions that were written by the attendees. And just a brief reminder, please write your question in the Q&A and not in the chat. I also would like to ask the understanding from all attendees, because that would be many more questions will be asked most likely than we will be able to address in this next 60 to 80 minutes. And those questions that are not addressed in live will be addressed later in writing, and we will post it on the ivfmeeting.com website. We also ask you, please do not use the Q&A or chat area for solicitation or any products of companies. If you miss any of the sessions, even from the past, don't worry, it will be recorded and available later via link on our website. Disclosures and bios of speakers and moderators can also be found on our website at the www.ivfmeeting.com under the 17th session. And now I would like to hand over this virtual microphone to my colleague, to introduce the roundtable participants.
Great. Thanks so much, Peter. I too am very excited about the lineup of participants for today's address, to address any questions about embryology in the IVF laboratory. I think this is going to be a really fun format. So it should be very exciting and quick moving as we pass back and forth between all the speakers. And hopefully all the technology works well with us. And just like with any IVF procedure, the key to a successful webinar has so much to do with the proper preparation. We are fortunate to have an amazing group of I3 panelists working behind the scenes to ensure a smooth presentation. They include Thomas Elliott, Jacques Cohen, Marianne Stevek, Alison Bartolucci, Tony Anderson, Liesl Neil Thamat, Shaista Sadruddin, Kelly Ketterson, Dara Berger, and Charlene Aloof. Without any further ado, it's my pleasure to introduce the panelists of today's roundtable. We're going to start with Dean Morbeck, who's going to speak to us about insemination, IVF and ICSI, and about lab setup. Dean is the Scientific Director at Fertility Associates New Zealand, Sun International Fertility Center, and an honorary lecturer at the University of Auckland. He oversees science in IVF clinics throughout New Zealand and Malaysia that annually perform greater than 4,000 fresh cycles. Prior to moving to New Zealand, Dean was an associate professor at the Mayo Clinic. Dean, please take the mic.
Great. Thank you, Dawn and Peter, and welcome everyone. It's great to be here again. I will start out by just pointing out I won't be spending much time on the insemination and ICSI. I'd like to refer anyone who did not see our webinar from last week to that. I think very engaging conversation about how much ICSI we use and how to improve our ICSI rates. So really the focus for this roundtable, although those questions are always open for that, the roundtable that I'll present about is, as it shows on my slide, that it's ART laboratory setup. And I'm just going to go through some of the specifics, really different areas of key points that we want to hit on. We don't have a lot of time. We could spend a whole session just on this. So ART laboratory setup. We'd start with what, of course, is the most important, which is air quality. That's what immerses everything that we do. It's the foundation. And, you know, I don't have to spend a lot of time on this, although, again, we could spend the whole day talking about it because there's so much about this that we still don't have complete agreement on. But this consensus document from 2018, I think, is a great starting point, and everyone should have seen it and read it. And really, we highlight things like, you know, what kind of filtration. Everyone should have HEPA. Obviously, in Europe and in Asia, there's a big focus on this regulatory-wise. But the chemical air filtration to remove VOCs is really critical. That's something that I think is absolutely necessary. The issue of clean rooms and how you define a clean room. You know, we are working in biological clean rooms versus, you know, manufacturing clean rooms where it requires really, really few particles, like for semiconductors. You know, this isn't something that we agree on either. There's some clinics that do go to that length. And then whether you would need an airlock to go into the lab, you know, do we need those levels of control? And then we have other areas of design, like, you know, what came out of this document, which made it clear that we keep andrology separate from embryology. We keep our supplies away from our embryology. They're in a separate room, and we off gas. So a lot of good elements that are in that document. So let's talk about some specifics regarding what different options we have in the laboratory. So if we look at the workstation options, here I show you kind of 3 levels of workstations, and there's probably a 4th one, at least really extreme, but let's just, these are the 3 most common. The first one on the far left is actually our pickup station in Auckland, showing you no hood, where it's on the workbench. We do have HEPA filtration, so we've got, you know, for the room itself, the HVAC is giving us good quality air. And there's you know, varying beliefs around the world about, do you need a hood to be able to actually just do your practice? Now, in the EU, you do, I believe. I know that it requires a certain class of air to be doing any of the work, which would require then this middle screen, which shows working in a hood with a laminar flow. And then the most extreme would be something like here, which is one unit that we also use here in New Zealand. This one happens to be just, you know, like an isolette, same function, where you've got complete control over temperature and gas, and potentially humidity as well while you're working. So you're basically working in an incubator. From there, we move on to the actual micromanipulation workstation. And I show this picture from far away because I want to point out a couple things. Obviously, this can be done in a hood as well. There are systems out there. There's a lot of new equipment in our field. If we were at one of our big conferences right now, you could see all the gadgetry that's out there. I've always used a standalone on the bench system like this. But I like to point out, you know, here's the above there, you see that's where the direct airflow comes in. It's not right over the top of this. So something we like to believe is important is to keep this pretty isolated from traffic and airflow. And so whether or not it's required to be in hood, again, is probably somewhat dependent on where you're located. And then I'll finish covering this section by talking about gas delivery and liquid nitrogen storage. And so this picture here is actually from our Malaysian clinic in Kuala Lumpur, showing our vapor phase storage along with liquid nitrogen dewars here. You know, just as an example, the first picture I showed about how we would function in Auckland is completely at the other end of the spectrum from what's being done in Malaysia, where we have a clean room setting. We have airlocks coming in. We have all of this really sealed walls, and so, but the delivery of gas to this, you can see that we actually have gas coming from an outside room that is allowing delivery of gases to the facility without bringing it inside the lab. I show you this picture, which is from one of the labs I've visited on some of my different trips. It's not one that I oversee. You see a couple of tanks in the room, which means that we're not having gassing available. This isn't ideal, and this should be avoided, especially here where it doesn't have them attached to the wall. For all of those of you who are following our OSHA standards, this wouldn't be acceptable. And then lastly, whether we're using big tanks or liquid nitrogen storage small dewars, this is a whole nother topic, and one that we've heard about on this webinar, and one that I think we'll continue to hear about, because I think we have to live with both large and small storage systems, and we need good monitoring of those for safety purposes. So I think that's all I've got, and we'll hand over to the next speaker.
Okay, while we're getting the slides turned over to Alison, I'd like to introduce Dr. Alison Campbell. She's currently Group Director of Embryology for the Care Fertility, where she plays a key role in establishing and integrating new laboratories. She heads up the embryology teams across the organization, which now constitutes 11 laboratories and many satellite facilities. And I see her slides are up, so go for it, Alison.
Thank you. Just check my mic's open. Yep. Thanks very much. First of all, just quickly like to say thanks for this opportunity. It's really a pleasure to be involved in this initiative. It's quite unbelievable what's happened over the last few months, and all the support that this I3 initiative has got. So I'm really briefly going to talk about QC, QA, and results monitoring. It's quite a personal perspective, but I'm hoping that it'll stimulate some questions for the panel. So QC, I'm sure we're all aware, it's required, it's absolutely essential, and it's there really to ensure that each element of our IVF laboratories are functioning correctly. Where I work, Care Fertility, we use a great app, Reflections. So all of our QC data, we manually input into this, our app. So completely paperless. It allows us to set limits and consider the ranges, look at trends, and monitor all the actions, preventative actions. So this is just an example from an incubator oxygen fluctuation and detail chart. So we've set the limits that we require, we enter the value every day, and then we can look and see what's been happening, spot trends. We just move on to QA, quality assurance, equally as important, a comprehensive program to look at the whole process of IVF. It helps us identify any issues with a view to correcting them. This chart here is just an example of internal quality assurance that we undertake with time-lapse annotation. So you can imagine it's very important when you're using algorithms for embryo selection to make sure that all embryologists are annotating similarly. So this is a plot of 7 different embryologists. They're annotating exactly the same video. We do this on at regular intervals, and we set ratings to show whether we've got an embryologist not conforming to what we'd expect them to if they are sitting outside our limits, which in this case they are. We're looking for an intercorrelation coefficient of greater than 8, which tells us that they are closely annotating in the same way. And most importantly, that the variables that we're looking for in our algorithms are consistently annotated. External quality assurance. So the World Health Organization describes this as a system of objectively checking lab results by means of an external agency. Also very important. The main objective of external QA is to establish inter-laboratory comparisons, comparability. In the UK, we have the NEQAS andrology scheme. It's a good example of external quality assurance. So 4 times a year we'll receive these samples, and this service is available around the world. And we're looking at sperm density, motility, and morphology. And again, all of our embryologists get involved in this, and we can compare as well across our clinics. So intra and inter and external to care fertility. Finally, a few words on results monitoring and KPI. And this again is a huge topic, so many considerations, but very important that we make them. Some examples are the frequency of results monitoring, how many procedures should we be looking at? We can't just look at a single one, should it be hundreds? Lots of questions which I hope we can talk about later. Which key performance indicators should we use? We know they must be objective, they must be relevant. We need to set benchmark competency levels, but also I think it's important to set aspirational targets. And the way to do this as well is to collaborate, to understand what other people are achieving and how you can continue to raise the bar. And we need to set limits so that we can trigger when an investigation is required. So I've just put a table of some of the values that we use at Care Fertility. We have green, it's an aspirational target. Purple, we set, and this you can compare with your own, but purple, we say it's world class, this is where we really want to be, but green is great. Amber, we keep an eye on this, and red, we need to take some action. Unfortunately, we have the Vienna Consensus, which sets some recommendations for minimum performance, so competency, and also for benchmark. And altogether, there are 19 indicators described in that excellent consensus paper, 12 key performance indicators, 5 performance indicators, and 2 reference indicators. So I think that's all from me for now, but I'll come back to you later on.
Great, thanks so much for a wonderful presentation, Alison. Next, I'd like to introduce Behr. I think most people are aware of who Behr is, but he's the director of the IVF ART laboratory at Stanford University and is faculty advisor for the Transgenic Knockout and Tumor Model Center. In the 90s, Dr. Behr developed a culture medium for embryo culture to blastocyst stage, which has improved pregnancy rates and implantation rates. And he's going to speak to us about embryo culture. Go for it, Barry.
Hello, everybody. Sorry about that. Trying to get back to my slides here. Thanks for that introduction, Dawn. Hello, everyone. It's truly a pleasure to be part of this team of experts to share some of my thoughts on embryo culture today. I want to thank Peter and Jacques and the organizing team for putting such a wonderful platform together, and of course Thomas's expertise and the rest of the team. So I'm going to spend the next few minutes just giving you some bullet points that will hopefully provoke some questions for us to address later on in this symposium. So I think there are basically 4 things that are important to consider, or 4 factors that we can consider with respect to embryo culture. The thing that most people talk about and what you hear when you're at conferences, you know, what media do you use? You know, do you use media A, do you use media B? This is the really the holy grail around what our embryos are exposed to. I'm not going to be talking about media composition specifically. Clearly, there are questions around whether some media compositions promote more euploidy or higher blastocyst formation rates. But as you'll see down at the bottom of my bullets here, it's really how you use these things more than the composition of the media, in my opinion, that can optimize the performance of any particular product. Of course, as Dean mentioned, you know, the local culture environment, the air, VOCs, the air that the embryos breathe, i.e. the gas concentrations, the atmospheric pressure that your practice is at will affect the pH. You know, the humidity, are you culturing in dry or humid incubators? As I'm moving down to the next factor with respect to embryo culture? What are the equipment that you're using? Are these big box incubators? Are they benchtop incubators that make maybe monitoring pH and other factors more challenging? If you use a pre-mixed tri-gas, for example, will be different how you monitor and adjust factors than if you have independent gases, for example. And probably most importantly, and most important on any of the factors with respect to embryo culture, in my opinion, is the standard operating procedures that you implement in your practice. You know, one size doesn't fit all. We're going to hear about running a small lab versus a big lab at the end of the presentations today. And what works for a 3,000 cycle IVF lab may not work for a 300 IVF cycle lab. But the most important is to adhere to good standard operating procedures. One example I want to mention is with respect to QC monitoring that Alison mentioned. How do you measure the pH in your benchtop incubator? That process alone can change your interpretation of your culture environment. So again, good QC measurements, adherence to good protocols and good policies are really going to optimize any embryo culture environment that you may have. Again, one size does not fit all, and there are many ways to skin a cat. So I'd like us to think about the overall conditions. It's not just what media you use or what's the media to oil ratio, or do you culture in groups or not. It's the overall conditions, and it's the accumulation of these conditions that ultimately are going to affect the environment that you culture in. And the big sort of acronym or term here is pH. I think pH is the best finger on the pulse for your cultures. Standardizing the pH maybe for the different culture intervals, understanding in your lab what does best. But in general, I've witnessed pHs decreasing over the years. We're more comfortable culturing now at pH levels below 7.30 than we used to be. When I grew up in IVF, we were culturing around 7.4. That was our target pH. And we've certainly varied from that, especially in the first culture interval. So I'd like to close with a controversial question. We spend most of our days, being obsessive and compulsive about maintaining our optimal conditions for our lab, static conditions, 37.0 or 37.2 degrees, CO2 at exactly one number, temperature at exactly one number. And none of us who have gray hairs grew up in that kind of condition in vivo. And I just wonder, for the future, question for the future, how optimal are the static conditions that we're striving to create in our lab for optimizing embryo culture? So I'm going to end with that, and I'm looking forward to entertaining questions when we get there. So thanks for your attention.
Barry, thank you so much. I think that was really great, some thought-provoking points and review. And the next speaker is Kelk, that I already introduced, and she's going to give a short overview about embryo evaluation, embryo selection, and embryo biopsy. Thank you, Dawn.
All right, thanks so much, Peter. Yeah, I think there's an overarching message from all of us that every lab has their own way of doing things. There's no one-off recipe, and I think that's one of the fun things that I find when I go out and do CAP inspections or when I offsite a lab and I see how my solutions don't work in every lab, and every lab has to find their own little ways of coping and know their own data. So I'm going to talk about embryo selection and considerations that all labs, I think, kind of go through are thinking about minimizing your embryo exposure. So how many times do you take the embryos or the eggs in and out of the incubator? Are you using media that we were just hearing about, single step media or sequential media? And there are more labs using time-lapse now. So is time-lapse a consideration for your lab? Or are you doing cleavage observations? Are you using those cleavage observations on day 2, day 3, day 4? Are you really using the data that you're collecting? And one of the things that I notice when I go out to a lot of different labs is they're busy writing all the data down, but they don't necessarily utilize that data to make clinical decisions. So I think it's all something to think about and be introspective about. is your lab doing assisted hatching? If so, what day? The number of embryos that you have available, does that determine whether you would consider doing a day 3 or a day 5 transfer? Some labs think a lot about uterine synchrony, and there are certainly more and more labs in the US that are turning into cryo-all, where they virtually cryo every cycle, freeze all their embryos, and then bring the patient back for an FET cycle later. And I think it is important to know your own data. That being said, hopefully my slides are going to advance here.
You have to use the thing on the bottom left, Dawn.
The bottom left.
Of the PPT, there'll be an arrow that should come up.
It's not giving it to me. Hang on one second. Let me see if I can get it this way. For some reason, oh, there we go. Okay. So at Yale, what we do is we strive to use minimal exposure, but also to balance the data that we want to get that we think is relevant data. So at Yale, we're using a single step media. We use global total media. We do not use time lapse, but we do a snapshot view, which is a day 2 observation, which is one of the primary algorithms that are used for time lapse. And what we do with that snapshot algorithm is that or that snapshot view, we sort our embryos on day 2 into like groups. So we'll sort into a 5-well dish. We'll sort our embryos that are 2 and 3 cells into one well, 4 cells into another, and greater than 4 cells. And what we historically looked at was when we biopsy the blastocysts that come from those embryos, the blastocysts that come from 4 cells or greater than 4 cells are much more likely to be euploid. So if we're not doing PGT, then that embryo selection can help us select the embryo that's the most likely to be euploid. So that was a very important observation for us. And so because we wanted that day 2 observation, we moved our assisted hatching to be done on day 2 so that we didn't have to expose the embryo twice. So day 2 hatching, we do a select number of patients with a day 3 transfer. So if it's an older patient that only has 1 or 2 embryos that's not doing testing, then we may very well defer to a day 3 transfer. Right now at Yale, across all ages, we have a lot of poor responders. Across all ages, we're at about 30% day 3 embryo transfers. We also do select cryo-all depending on a few factors. We do select cryo-all when the progesterone is elevated on the day of trigger. So for us, using a Roche E411, that means a progesterone of 1.2 nanograms per mil. And that's where our pregnancy rates start to drop. The Roche is particularly sensitive in that range, but some other assays aren't. So again, you have to know your specifics of your particular lab. We also at Yale would turn into a cryo-all if we had a very early blastocyst like the one shown at the bottom right. So what we want to see on the morning of day 5 is a 2 BB or better. So if we've got early blastocysts in a fresh cycle where it's a stimulated uterus, we'll turn those into to freeze-alls. We'll culture them out to day 6 and cryo-all at that point. That being said, this particular embryo was from an egg bank thaw. It was transferred on day 5, and that's because in that egg bank thaw, we're actually working with a frozen uterus, so with a hormone replacement, so we could match the synchrony better that way. So all considerations that we have. For those of us that are considering embryos for day 5 or day 6 biopsy, we have considerations for whether you zone a breach on day 2, 3, 4, or with biopsy. There's lots of labs out there that are just breaching when they go and do the biopsy, and about as many different opinions. Do you consider your lab schedule? Of course, you know, you have to have the the embryologist's time available to biopsy when the embryos are available. And you have to work practically within the rest of your confines. Considerations of embryo expansion, how cellular the embryo is, position of the inner cell mass, the best time to VIT, whether it's immediately or whether you allow the embryo to re-expand, whether some places recollapse the embryo even after it expands after they biopsy it. And knowing what your best survival is, and again, knowing your own data. So at Yale, we breach on day 2. The majority of our embryos are biopsied on day 5, late on day 5. Greater than 60% of our biopsies are performed on day 5. The rest are performed on day 6, with very rarely embryos being biopsied on day 7 if they're progressing nicely and they're just slow. And occasionally we do get a euploid embryo from those day 7 embryos, but again, it's very rare. So for our hands, what we would generally use is about greater than or equal to 5 cells hatched out. So if we're looking across the band of embryos at the top, obviously we wouldn't be biopsying the first embryo or the second one. The third embryo is where would be the earliest limit that we would consider biopsying. And obviously we like to see more advanced stages. And the majority of our embryos look more like the 4th embryo when we biopsy. So for us, there's little consideration of where the inner cell mass is. We tend to just work around it, unless it's just really in the wrong spot on day 5, and we might let it go to day 6. Obviously, for us, what we do is we biopsy all the embryos, we VIT after tubing, so that takes about 30 to 60 minutes. So we allow for partial re-expansion, but not full expansion. And this is just a fun slide that I thought I would pull up again from years ago, and that is which of these embryos made a baby. And when we try and pick, it's frequently not very apparent. And the truth of the matter is, with all of these embryos, every single one of those embryos resulted in a baby being born. So my favorite's the bottom one, where there was a singleton girl. That's my most favorite ugly embryo. Anyway, so I'll pass it back. I'm going to pass it on now to Maria Jose de los Santos. She's the director of the clinical embryology at IVI Valencia and designated participant from Spanish government for the 3rd and 4th edition of the Guide to the Quality and Safety of Tissues and Cells for Human Application of the European Council. Oh, you got to unmute. Hopefully she can unmute.
Okay, thank you. Yeah.
Good job.
Here we go. Thank you. Okay, thank you very much for the invitation. I was in charge of presenting the cryopreservation part of this webinar. It's really a pleasure to be participating in this initiative. So congratulations to the organizers. So I think let's go and get into it. I think oops. I don't know why it's not working. Okay.
Use the arrow on the
Yeah,
bottom.
okay. I think we agree in saying that reproductive cryopreservation has experimented a huge and a significant increase in numbers, in improvements, in results, and probably is because we have implemented vitrification techniques in the majority of the IVF laboratories. As you can see in these figures, there is a high proportion of IRT techniques that has been applied in either in the States or in Europe that relay actually in the use of vitrified material, cryopreserved oocytes or embryos. And here you can see a list of possible clinical situations and may also explain part of the figures that I have shown in the previous slide. There is situations where you need to freeze all the embryos to increase your outcome. Now, reproductive cell, and especially oocytes, as you may remember, were extremely sensible to cryo-injury. And there were some issues related with this sensibility to cryopreservation. As you may remember, there was an issue related with lower surface volume rate, issues related with membrane permeability or disposition of the cytoskeleton or the spindle cell cycle. So when vitrification came into play, all these barriers that made oocytes and embryo more vulnerable to cryopreservation was actually solved. And we have very good survival rates. And as you can see here, as many of you may have seen these reports, Alpha Consensus and Yelena Consensus reporting the cryopreservation key performance indicator show that we should expect benchmark values ranging between 80 and 99%. So we should expect values of 80% mostly in oocytes and zygotes, and more than 80% for cleavage stage embryos and blastocysts. But still, even we have very high survival rates using vitrification, there are some embryos, some specimens that do not survive. And we have actually identified what are the factors that may affect these survival rates. So some of the most important one will be maternal age and also poor embryo quality. But also there are other, let's say, external factors that may affect survival rates of our specimens. Low culling and warming rates. Everyone knows that if we don't pay attention to the culling and warming rates, we decrease the survival rates. Inadequate handling and storage condition is another factor. Also, sometimes we need to repeat cycles of warming and vitrification or do biopsy twice to the embryos because we don't have results at the PGT. So those factors we know for sure that will affect negatively to the survival rates. On the other hand, the factors that you see in the right-hand side of the slide are the factors that may not affect or may have a little effect on the survival rates. So we know that embryos can be vitrified at any stage of development. I put in question mark hatching blastocysts because maybe those ones are more tricky and they have more problems to survive. But we know already that the oocyte dysmorphism doesn't affect oocyte survival rate. The biopsy per se does not affect the possibility of embryos to survive, neither the type of RNA stimulation that we use, time of storage, induction of blastocyst collapse. So there are many factors that we know affect and do not affect the survival rate of our specimens. And last but not least, I will bring your attention to the safety of cryopreservation because we were very happy using vitrified oocytes and embryos in our cycles, but knowing that we still require more, let's say, studies, large-scale population studies to look to the long-term consequences, so far we can say that perhaps oocyte vitrification does not affect the obstetric and perinatal outcomes, but maybe we cannot say the same to when we transfer vitrified blastocysts, because the transfer of vitrified blastocysts has been associated with risk of women having placenta accreta, preeclampsia, hypertension, and also a higher risk of having babies with large for gestational age syndrome. So I leave this slide, I leave this this situation, a question mark open for you to think about it, because I think it's something that we should not forget. So I try to be very brief, as I promised, and this is it. Thank you very much for listening, and I'll be happy to answer any question that we may have during the roundtable. Thank you very much.
All right, thank you so much for that great talk. I'm going to pass it next to Yelena Pasman, who's going to speak to us about managing small IVF labs and smaller programs. Yelena Pasman is a senior embryologist with over 25 years experience in the areas of genetics and assisted reproductive technologies. For the past 15 years, Yelena has assisted medical and laboratory directors in overseeing the clinical laboratory regulatory compliance operation. Yelena has provided support in all areas of the clinical reproductive laboratory services to medical centers in South America and the United States. And we've got her slides up, so that's great.
Can you hear me? Hello?
Perfect, thank you.
Perfect, yes. So I managed to get off my phone and join the Zoom. Thank you so much, Peter, for inviting me. It's truly a pleasure to be part of this IVF panel and participate in this amazing series of meetings and educational events. Today I will be presenting challenges of managing a small laboratory. So I joined Nevada Fertility Institute in the middle of 2018. Nevada Fertility Institute was built in 2017 and performed their first IVF cycle in July of 2017. The clinic budget included 1 physician, 1 nurse, 1 senior embryologist, front desk staff, and medical assistant. So we had a lot to do. The volume was very small, but we had ambitious goals. We needed to apply for CAP accreditation. We needed to earn reputation among existing clinics in Nevada and increase our volume. So our volume in 2017 was manageable, although 1 senior embryologist was covering andrology and embryology lab. And in the beginning of 2018, it became apparent that the volume is growing, but we did not know how fast it will be growing. And that became actually obvious to us by the end of the summer. And we started to look at the numbers, and we predicted that based on the growing amount of cases, specifically semen analysis, IUI, we were facing tremendous increase in IVF cases and IVF cases with frozen donor eggs in 2019. So we reached out to the community. We recruited 2 newly graduates from college, and we implemented 2 lab intern positions. And we started introducing them to the lab. They were shadowing myself and physicians. And by the December of 2018, we realized that we really needed another position. Although the volume was growing, we needed to justify the position. That was the hardest part, and I'm sure everyone is facing the same challenges. How do you go from one position to position? So we needed to come up with numbers. And luckily, we monitored our numbers very close, and as predicted, IUI numbers grew, and that reflected our numbers for IVF cases and number for IVF cases with donor eggs. Here you can see the change from 2018 to 2019. In January of 2019, when we suspected the increase in volume, we started to train interns, and by the April of 2019, they were fully trained and were able to contribute to the laboratory, and they saved lives. And they made it very easy for us to transition from low volume to medium volume. And here I would like to have for you to look at the slides for IUI and data from 2017, 18, and 19, and how this increase in IUI reflected the increase in IVF and an increase in IVF with frozen eggs. So we monitor our volume very closely, and it's not only volume for the lab, andrology or embryology, we also monitor volume and outcomes for IVF and IUIs, and that gives us opportunity to be on top of challenges in the lab and be proactive and make sure the transition from low volume to increasing volume is addressed immediately without consequences to patient. And most importantly, it's easier for everyone enjoying their job. Not every weekend that everyone has to work. We balance work and life, and those numbers, by monitoring those numbers, really helped us to go through this challenge. Thank you.
Yelena, thank you so much for this presentation. From this panelist group, I think everybody else is working in an IVF center that is, large volume IVF center. I think you are the only one who is representatives from a small IVF center, small volume. And, I think most of the IVF centers, not only in the US, but also in many other parts of the world, they are actually small IVF centers, So I think it's really very important to get your perspectives. And I understand that, one of the challenges that when volume grows, how to adjust, the people that are working, and, whether you are overworking yourself or trying to get a new person engaged, it's not easy. Thank you so much for that.
Sure.
So now we are going to go to the question and answer part. We have probably about 25-30 minutes left from this webinar to go through those questions and get some answers. I have a very different questions, if I may start to ask the question. which is related about what we all experience in the world, which is the coronavirus pandemic, which is unfortunately affected, the patients, affected all of us in the IVF clinics. I'm just wondering that from the panelists that are here, how many are currently running the IVF clinic? So I'm sure that some of you have stopped, but I'm sure that some of you have started. So how many of you are actually running IVF clinic now and seeing patients? 1, 2, 3, 4. So basically everybody. Okay. So can I ask you, how are you doing logistically differently, or are you doing the same like before, or you are doing something differently, and what you are doing differently? How do you care about the patients today? How do you care about yourself and the stuff around you? Just very briefly, who wants to go ahead? Barry, please.
Thanks for that very important question, Peter, during these crazy times. Here at Stanford, we have opted, based on the permission by the local government, the county, and our institution, to permit non-life requiring treatments like IVF and other surgeries. We have changed our workflow significantly to avoid log jams in our waiting room. We're checking patients in from the parking lot. We have reduced the volume of cycles that we're starting to make sure that we don't have congestions to maintain social distancing. We are not going crazy in the laboratory with respect to overly cleaning. I would say that the standard cleaning procedure we were using before is being maintained, with the exception of probably doing more doorknob cleaning and things that we didn't do before, just as a precaution. But we understand now how the virus is transmitted, and we're taking all precautions to avoid social distancing or to maintain social distancing, avoid crowding, and limit the number of patients that are going through at a time to ensure we can maintain safety. I think it's much easier to get hepatitis than it is to get COVID, and we treat far more hepatitis positive patients than we do COVID positive patients. One other thing, that all patients are being tested prior to starting treatment as well.
Yes,
and ask social distance prior to them embarking on treatment.
Thank you so much. So I will ask you, Dean, next, because I know that you told that in New Zealand, there is no more officially coronavirus around, and I think New Zealand is one of the very few lucky countries that they don't have to worry about this problem anymore. And I think the only excitement remaining is the earthquake here and there, time to time. I think 3-4 days ago, I saw the Prime Minister giving an interview that, just in the middle of the interview happened an earthquake. She kept her cool. I mean, you have a great Prime Minister, congratulations. So how you deal with, the current situations in New Zealand?
Yes, thank you, Peter. We are fortunate with our Prime Minister, and here in Auckland, we don't feel the shakes like they do in Wellington, so I doubt you'll see me moving. But not only am I in the future in terms of it's already Wednesday, but hopefully in the future for many of you in terms of a coronavirus-free world, where we've had 3 cases in the last 2 weeks. So we are back up full, but we did many of the things that Barry mentioned, and I appreciate Barry pointing out hepatitis. And the other infectious diseases, I mean, there's been a lot of hype and overreaction because we didn't have good data on this coronavirus, and yet it is a coronavirus. So, all you have to do is go to a blood bank and see how they practice, and they didn't change in terms of the screening. So, in terms of what risks we have in our labs, it's really mostly between each other, and we just wear masks and make sure we don't infect each other. But we've moved from 2 teams down to 1 full team, and actually now we're kind of over capacity in terms of patients because of all the backlog. So I will be going down to one of our clinics potentially next week to pitch in because it's quite busy.
Thank you, Dean. Anybody else wants to add to this if you do something differently, additional? How's it in Spain? Because I know that Spain was one of the countries that was hit very, very hard with this pandemic.
Yeah, well, we were hit it, as you said, very hard with this pandemic. Not all the countries, for example, Valencia was, the prevalence in Valencia was not that high, but to my view, there are many questions that are unsolved with regards of the effect of the coronavirus on the health of the babies and the mothers. So to me, it's like we are just using big balls to solve us. We do the same that Barry does and Dean does. We do IgG testing and PCR before the patients do the transfer, because we want to be sure that they are at least at the beginning with good health conditions. But more than that, we cannot do anything. It's like the Zika virus. I mean, people are coming with no Zika and then go back to Brazil or to other countries and they got the Zika. We cannot control everything. So I think our responsibilities as clinicians is to evaluate things on risk basis. And so far, the risk is so tiny that we should not be so worried about the situation. I mean, we need more data anyhow, but so far I think is people are too afraid of what actually is happening. Well, this is my point of view. I don't know whether you agree with me, but
okay. Thank you so much. I think this was just a ad hoc question, really. I think we should go back to more the procedural and technical questions that the presentations were about. Dawn, if you want to go ahead.
Sure. I have a question that seems to be, it could be for anybody in the panel, but perhaps more so Dean, maybe. Do you consider the splitting of a cohort of eggs, providing it is large enough, between ICSI and IVF to be a useful treatment strategy?
Yeah, great question, Dawn. I have done that in the past. I don't do that currently in either New Zealand or Malaysia. I like to go all in one way or the other. I think it's useful for those that are really on the fence, where they've had maybe not such good results with ICSI and they want to just see if they can make it work. So I think on a case-by-case basis, but not as a standard. And I know there's some groups like Peter that do this extensively. It requires more work, of course. And then here in New Zealand, we actually have to track whether a baby's from IVF or ICSI. So it also means we have to keep them separate.
Thank you. And if I may just add to that, I think it's very important that every IVF laboratory is basically looking at and checking their own results. Some have better outcomes doing conventional IVF. Some has equal with conventional IVF and ICSI. Look at your own outcomes. And then what is the best to do for the patients. Yes, Barry. Unmute yourself. Yeah.
Dean, a question for you. If you have a patient with good semen parameters and good, failed 3 or 4 IUIs, and they're moving on to IVF, are you just going to assume it's a female factor and you wouldn't do a diagnostic ICSI IVF split? I mean, that's what we do. Rarely go from ICSI back to IVF, typically the other way around. But I just wondered, when you have an unknown, are you going to go all in on a case like that?
Absolutely. Yeah. I mean, based on what we've seen as far as, the impact of ICSI on blast embryo 2PN to blast rate, we still prefer to use IVF if we can. So it has to be, usually that we don't have enough sperm or prior failed FERT with IVF.
Okay, quick question to you, Barry. 3 people asked very similar questions regarding incubators, dry incubators, humidified incubators. Is there any difference? Would you prefer one over the other? Mohit Karkal, Alpesh Doshi, Abdullah Mohammed asked those questions, Annabella Marconetto. What would you say?
Well, I would say in a perfect world, I would like a humidified incubator. But I understand, and in a perfect world, I'd like an incubator that can recover fast. And it seems like the incubators that recover fastest are benchtop incubators that are mostly dry. And because of the total effect that I was trying to sort of bring out, you can use a dry incubator safely if you follow good operating procedures. And I alluded to the media to oil ratio. I think you will be in trouble if you use a single step media for 7 days and you have too much media and too little oil. I think you'll be fine using a dry incubator if you have a lot of oil and a little of media for shorter time. So it really depends on how you use the individual incubator and how you set up your drops in your dish to ensure that you don't change the osmolality of the media during your culture interval. Jason Swain has published nice work on the advantages of humidification, or he's talked about it. He didn't publish that work, but he's talked about it quite a lot on the advantages of humidification. And I see that, but I also think you can mitigate those advantages by using a dry incubator well. Humid benchtop incubators are more prone to problems, and I think that's why we don't see many models that are dry. Sorry, that are humid, mostly dry.
Sure, thank you, very done. Okay, sorry, Alison?
Maria?
I was just going to say about oil. Yeah, I know I completely agree with you, Barry. And you know, it's been quite a revelation relatively recently when we did some testing with different oils, and a really heavy duty oil can be incredibly protective.
Well, we have made some comparisons using Jerry incubator with, you know, that we can work with humid chambers and not humid chambers. And we have seen that when you work under humidity, you can have an increase in a number of embryos of good quality, but this does not have an impact on pregnancy rates, neither ongoing pregnancy rates. So, you know, it's also important the amount of culture media that you have. But I have to say that we are not using heavy mineral oil. We are using light mineral oil. And, you know, we just see an improvement when we use humidification environment, but not very high. And as I said, there is no impact on pregnancy rates, not ongoing pregnancy rates.
The only concern, Maria, there is that you're stuck to their dish. So if you wanted to try improve the results, the embryo quality with your dry system, you can't change the drop configuration in those pre-made dishes. So I would argue that if you could change your oil to media ratio, you could achieve the same embryo quality in a dry system.
Wonderful.
All right, I'm going to change the question up if everybody's good with that. I have a question here that says, is any of the panel concerned about the now copious use of alcohol-based hand sanitizers around our clinics and potentially in our retrieval and embryo transfer rooms?
I'll take that one on a bit. I may be in the minority, but I'm not overly concerned because when you look at the effects of ethanol on culture, it's, you know, like activating the egg is like 7%. Most of our culture now does not involve large incubators with humidified water pans. So back to Barry's comment about working in dry, if you're not working in a humid environment, then there's going to be less concentration. So since we work in mostly closed systems that don't have that pan, we're not going to concentrate alcohol. We want to keep it obviously out of the laboratory, but if it's in the facility, and being filtered through the system, I think it gives us the most, you know, powerful cleaning agent possible for those sites, so that we can provide assurance to the patients and clean quickly, because a lot of the quaternary ammonium products require, you know, the 15 minutes of waiting for it to act. And hydrogen peroxide isn't always, you know, active. It can go lose its activity. So ethanol still is our best option for washing hands, say. So no, I don't have a concern, although I don't allow it in the laboratory.
It's only for external use, I suppose.
For what?
It's only for external use. It's just a joke.
Very American.
Any other opinion? Yeah, Barry?
Peter, one thing I'd like to comment that we noticed in our facility, we have a life air system in our laboratory here. It's about 4 years old now. And when we first moved in this facility, we didn't allow the alcohol into the lab, but the procedure room that shares the same air handler They were use copious alcohol between, I mean, we would like do brain surgery between cases. It was crazy the cleaning they would do. And we found out that our life air filter got used up 6 months early because of the copious alcohol use. So it didn't affect our embryos. The system absorbed it. They, you know, I can't talk about the system much, but I can tell you there were effects not on our embryos, but on the life of our filters. And when we switched to hydrogen peroxide cleaner, which does require an extra time to sit, only a couple of minutes though, our filter life restored to normal. So there are effects on the outside.
And I'd just like to, good point, Barry. One of the things is that, so Dawn, I think the question originally had to do with hand washing, but in general, cleaning the theater or the procedure room, we still say it's best to use something other than ethanol. If there's a need to do something, use minimal amounts. So again, to Barry's point, yeah, we still are really trying to avoid its use as much as possible.
Excellent.
Maria?
Yep.
No, I just wanted to point out that at least in my experience, we have high pressure in the lab. So if you use ethanol in your surgical room, there is low probability that the ethanol will get into the laboratory because of the difference of pressure. This is one point. And also, once I don't use ethanol in the lab, only I use the ethanol at the end of the day, in between cycles or between patients. I don't clean up with ethanol. But if you have a lot of recirculation air, the ethanol that you may create will be clear up. They will go up very fast out of your IVF laboratory. So I don't think we should be worried about the concentration of alcohol in the environment of the lab.
Excellent. Yelena, a quick question to you. How do you monitor results? Do you use KPIs? And what is the actual value of statistics in a small unit where you have very, very few patients, very few cycles in a year? What's your suggestion about that?
We monitor, we have a threshold. Obviously, we got prepared for CAP inspection. It was advantage for us. We started all from the scratch based on outcomes that is in the lab. So we monitor outcomes, we monitor volume. So every month we tally the numbers and we present data to physicians and nurses and clinical staff. So we all get together and we discuss the numbers. We also have a very tight schedule. We have a schedule that is set for a year. We know when the cycles start. We know when cycles are going to get retrieved. All our travel between different states, depending on that schedule. Also, advantage of small lab versus large lab. We can definitely stay within the schedule. So if we are planning to perform 15 egg retrievals in June, I prepared my lab, I ordered all the supplies, and I know that I will use drop exactly to the drop I ordered of that media, maybe a little more for backup. But I'm not wasting any supplies, I'm not wasting any reagents. My time is set. I know exactly how long I'm gonna be in the lab, when I can travel back home, how many weekends will I work. And I have a plan for next 2 weeks to do something else for the company. A big advantage if you are stick to the plan, if you have great communication, you not only be happy at work, you can also save reagents and supplies and plan your time off and plan your educational event if you want to. So it's really great work and life balance.
Okay, thank you. I see here a very quick remark that was going back to the question on the alcohol used in the lab from Mina Alicani, saying, I disagree with you, Dean. Hand sanitizer should not be used in labs and procedures room. Washing hands with soap and water is the best solution.
Yes, actually, washing with soap, I agree, is something we use for the laboratory. So just to clarify, I didn't say to use it for the lab. We have sinks going into the lab to use soap. That is the best option. But we do, you know, and back to Maria's point about the pressure, and it ties in with Barry's, is that while positive pressure is good, if the room air is being used, like if they're both providing air to the same HVAC, then that's going to be recirculated back. So there is that potential, which is why Barry said, I think his system filters were maxed out. But again, I think when we talk about ethanol, it's theoretical about its impact. We know that it has an impact at least 7% concentration in the studies of oocyte activation, but what is the actual amount that gets into drops when you're in a dry environment?
We don't know.
I don't know that we have that information, and I think again it's very theoretical that it can be a risk, of course, but and so therefore we keep it to a minimum, and it's very important, and we keep emphasizing it to the entire theater staff and the clinic as a whole. But when it comes to safety for everyone else, we start to have to make a choice and a balance between the safety of individuals versus a theoretical risk for embryos.
Excellent. Dawn, what's your favorite next question?
So I've got one here that says, what are your thoughts on the use of HEPES buffered media during retrieval, ICSI, and biopsy steps? Should we strive to completely eliminate HEPES from our culture systems? If so, can you share your strategies? Is anybody, Alison, please.
Well, I don't think there's an issue with HEPES. It's very commonly used. It's well established. To be quite honest, many moons ago, somebody said to me, somebody I very much respected said, oh, it's bad news. HEPES is bad news. Don't use it. So for many years, I didn't use it. And then we've acquired new laboratories who have used it very successfully. And I'd say it's absolutely fine. Generally, though, I would use MOPS buffered medium just by preference, but it's just more used to it. And when we've done some comparative analyses, I'd say that the MOPS is just, it's more forgiving. You've got more time. So if you've got less experienced staff, not that you want to encourage any slow working, particularly with ICSI or biopsy, it is more forgiving because we measured the pH was stable at 37 degrees for 5 hours, compared with HEPES, which you're maybe half an hour or so. So I think they're the differences, but I think they're both absolutely fine.
Okay.
A quick question. How do you ensure consistent and effective embryo selection by embryologists within a team? Kelk, what do you think?
Well, I'm just going to answer quick, Dawn, because I loved your picture of those embryos that made babies. And we've been doing a lot of work on that lower end. It's an area that we've, really haven't focused on as a field. We've talked about what's the best embryo, and we want our staff to be consistent in terms of the best embryos for ranking to get the patient pregnant the fastest. But I think I'm going to take this opportunity to put a plug in for a paper we just have in JARG that'll be out shortly, which essentially shows that we're really bad at comparing the lower end. Like, what do we define as viability? And are we throwing away embryos that patients have a chance for? And do we consider patients' wishes in terms of those borderline low quality embryos? So to answer the question, we use, of course, any external quality assessment. We're trialing and working with the ART Compass system, and there's other internal systems as well that we're trying to set up so that we can get it as tight as possible, recognizing that we'll probably never be as good as something like machine learning and AI.
Thank you. Dawn, you want to add anything to that?
No, I think that's true though about the embryos in the lower end, and I always sort of say that an embryo in the trash has a 0% chance at pregnancy as opposed to one that goes in the uterus. The one thing that I do really like about SART, and I'm not sure if everybody out there, I mean, there's a lot of worldwide population on here as well, but one of the nice things about SART expressing their data the way they do per retrieval is that we're not incentivized the same way we used to be to transfer too many embryos in one transfer. So that's one aspect that I do like about SART. We can take our time, transfer one embryo at a time, and we've got 12 months to get the job done. So I think there's time for us to take those lower quality embryos, and they might be second or third choices, but there's still opportunity to get those into the uterus. And I think when I talk to patients, if I say, well, this embryo's got maybe only a 10% chance at pregnancy, as opposed to a 50+% chance at pregnancy, that patient still wants the 10% if you ask the patients for the most part.
Excellent. I have a quick question to Maria. It was asked, storing vitrified eggs and embryos in vapor and not in the liquid of the nitrogen, is it a viable option? Is it a safe option?
Well, I think it's a safe option. As you may know, we started vitrification more than 10 years ago in 2000, no, more than 8 years ago. And we have doing warming cycles of patients that has been coming back 4 or 5 years later. And I can tell you that there is no difference whatsoever in terms of survival rates on those embryos. What we have noticed though is that embryos that has been stored in vapor during long time, let's say 5, 6 years, they need more time to be out of the leaf. You know, when you do the warming, the embryos is like more dry. I don't know, maybe it's because it's related with the vapor storage system, but you need more time for the embryos to be removed of the cryotop. And my suggestion would be that not to push not to rush the embryos to be away of the cryotop, just to leave 3 minutes, 4 minutes, whatever they need to get out of the cryotop. And I can tell you that the survival rates of those embryos will be equally high as the ones that has been vitrified 1 month ago or so. Yeah, so far we didn't have any type of cross-contamination. Survival rates are very good. We have been doing comparisons between tanks, times of storage, and no difference in survival.
Excellent. Dawn, do you want to add anything to that? Because I know safety of cryo storage is also kind of your interest.
Yeah, I definitely always feel more comfortable under liquid. It's just that extra comfort for sure, especially with vitrified embryos in those very small quantities of very small volumes, especially when you're handling things. So.
Okay, Barry?
Yeah, I'd just like to add, I think I agree with Maria that vapor storage is perfectly adequate. But if you're looking for cushion and extra security, you have a lot more time to react to a problem when you have immersion in liquid versus vapor. So it's just a what if with vapor that concerns me, unless you have exquisite monitoring.
Yeah.
Excellent.
Well said, Peter.
We do have exquisite monitoring, but
Wonderful. Dawn, what's your next favorite question?
I have, what does everybody think about group culture? What about 15 or more oocytes under 500 microliters of media during 7 days? Or what would your embryo to droplet size ratio be?
I'd like to just start this by saying we had a case where with group culture and PGS or PGTA, that extruded cells bound to each other and it was not possible to get them apart. So definitely something to be aware of. And I think this could happen even if embryos are hatching, although I'd never seen it in all my times of doing group culture in the past. And usually it would be, say, 4 embryos in a 50 microliter drop was my standard. I think you could probably do 4 and 30. But having moved to micro drops, so well in the well, I do all single drop culture and think that's perfectly fine and probably just as good. It keeps embryos from being disturbed, gives them a little microenvironment to work in. So I'm a big fan of well in the well concept.
Thank you. there was a question, and that's a quick question to everyone perhaps. What is the ratio between number of IVF cases and embryologists? Anybody wants to give a number?
Yeah, go ahead, Alan.
Yep. No, Alison, go ahead.
Okay. Well, I've looked into this. Of course, it depends very much on the skill level of the embryologist, on the support staff, the technicians, the nurses. It's not, there's no simple answer. But if I had to pick an answer, approximately 150 fresh cycles per embryologist is where I would sit.
Okay. Anybody has a different opinion?
Yeah, so I'll refer everyone to Mina Alakhani's paper, I think in fertility and sterility. That's outstanding tool. It's actually got a calculator on the FNS website that I used extensively, because with freeze-alls, with a lot, we're doing as many or more frozen embryo transfers as fresh. So what we've seen is the number of OPUs per embryologist go down as we've seen more and more of these other types of work go up. And when you factor that in, I do an OPU equivalent that I calculate using that formula, and we're more like 120 fresh OPU per embryologist, but the equivalent is actually similar to 150 when it looks at it as an amount of time. So I agree with Alison as far as it's about 150, but it's an equivalent. And the point about experience is important. The other thing we don't have a good way of controlling for is when we're training someone and when they start to gain skills, and how much time it takes away from the person doing the training. And every lab's different, whether they have someone dedicated and can take out of the rotation to do that. So it really is complicated to know what's the right number when we see such a flux in our systems as far as staff.
Okay, thank you. Maria?
No, I just wanted to point out that, yeah, I agree with these calculations, but also for those labs that are that do not make complex cycles, like they don't do PGT or they don't do extended culture, they may have to adapt these numbers, because it's not the same that you have an egg donor program, for example, in your unit, or if you run PGTs or you run extended culture. So it is important to make these scenarios and make these calculations in terms of number and complexity of the techniques that you are applying in your lab. And I agree with Mina Alakhani's paper. It's very nice. I like it very much. And we should do something very similar also in the EVRMA. Yeah.
Okay, done. One more question.
Oh, okay. I thought Yelena was going to chime in there for a second on that last.
Yelena, go ahead.
Based on my personal experience, when we just started to become very busy, and it happened overnight, we completed 150 fresh IVF cycles and 40 FET, and I managed to be by myself in the lab. I also covered andrology lab. That was overwhelming, and I was very happy to have someone in the lab and ready to train. When andrology lab was off the table and person took over the andrology lab, I completed 180 IVF cycles by myself with about 60 FET, and it was very easy, as long as I didn't have to run around between two labs. So I would say 160 fresh IVF cycles are manageable. So I totally agree with Dean and Mina Alakhani's paper.
All right, done. Maybe a last question.
Okay, my last one here is from Jacques Cohen, and it's a question for Barry. What is your opinion on minimal changes, observations, and culture changes, minimal pipetting? Do you think it makes a difference?
Thanks, Jacques. That's a good one. I've been, Jacques Peter is my mentor too, and I learned a lot from Jacques in your lab like 30 something years ago at RBA. So thank you for that, both of you. Jacques, my philosophy and my approach is to leave the embryo undisturbed. I've never done a study to show that it translates to better embryo development or better outcome. I think the less interruptions provide for less opportunities for problems, not that interrupting, if done well in an isolate, as Dean showed, or under a gas bubbler, or using heaps to maintain the pH, will not be equally well to leaving something undisturbed. So I don't think it's black and white, but ideally, you know, just to bring this full circle, to Dawn's point, we hatch on day one. So when I do a FERT check, I have I move the 2 PNs away from the 3 PNs, away from the non-FERTs, etc. And I confirm that on my inverted scope that has a laser. And I don't hatch all the way. I do a little scallop so that the embryo is encouraged to expand a bit and not just, you know, fall out of the zona when it's, you know, 10 cells or 12 cells. So I then leave the embryo in culture for 5 or 6 days uninterrupted, because I'm not doing anything to help it select or help it grow. I would argue if taking it out on day 3 to look at 4, or day 2 to look at 4 cells, as Maria did, to help me in cases where I'm not doing PGT, or Dawn said, sorry, then maybe interrupting is better than non-interrupting if there's something actionable. So again, I don't think it's one or the other. You can do interrupted culture well, provided you take care of all the details, but not disturbing the embryo certainly can't be worse than interrupting it, unless static conditions are bad, which I think, you know, we can talk about at another webinar. So hopefully that answers the question, more of a discussion than an answer, but thanks for the question.
Thank you, Barry. Anybody else wants to add to that point? No? Alison?
Yeah, no, I'm with you, Barry. I think the benefits of leaving the embryo, at least in standard incubation, uninterrupted, probably outweigh the benefits of these limited snapshot daily or once or twice in a week observations. And I think the more we learn from time-lapse and continuous monitoring, the more confident we believe that. And that's certainly the way we're moving.
Right.
Exactly. And I think now we are starting to arrive to the time when we are going to conclude this webinar. But before stopping it, I just wanted to ask every participants of the roundtable, you know, if any of you want to provide a brief concluding remark, and also, you know, if you have any advice or suggestion, what we are going to look into the future, you know, anything to look out, you know, new inventions, you know, anybody wants to start with it?
Well, I'll just do a quick sum on mine since I was first, and just to say that air quality, it can't be stressed enough, but it's mostly around chemical air filtration. So showing the different hoods and things, there was a question I noticed in regards to that, which is all about particulates. And depending on where you are and what your particle counts are, then having a laminar flow hood for your work is potentially important. But if you don't have a high amount of say bacteria or particles, then I don't think it's required.
Thank you. Any other wise words? Alison?
Yeah, I didn't prepare this at all. I was just thinking to myself, we've not mentioned it, and I don't think you hear it very often, but I think there is some value in intuitive embryology. I know, thinking about results and KPIs, you know, it's all there documented, but sometimes if something doesn't feel quite right, it probably isn't. And that's when you also need to step in. Don't always wait for 50 cycles of data. Act as soon as you feel something may be wrong.
Wonderful. Thank you. Done?
I think the thing that I'm looking forward to over the next little while is I do believe that non-invasive PGT will be getting there one day. We're not there yet, but I'm looking forward to that continuing to develop. So.
Fantastic. Thank you. Maria?
Well, I see the future of embryology with the help of artificial intelligence to evaluate the embryos with no difference between operators, and also they will allow to the embryologists to use the time to analyze the data. That is very important for to increase the results, the outcome for our patients, because sometimes it's like we are just doing it and evaluating embryos and we forgot the analysis part. And this is very important, as Alison said. We need to analyze the data that we have and do acts in consequences. So we need to know what we have in hands, and not just to do ICSIs and transfer and retrievals. We need to analyze data. And if artificial intelligence can help it in that, I will vote for it.
Thank you. Yelena, anything you would like to
Yes,
add?
I just want to add to Dean's comment about the air quality. We were fortunate enough to operate the lab in Nevada during the lockdown in April, and we noticed unbelievable phenomena. It was not a single car on the road, and our blast rate went from 70% to 85%. So we definitely, not a single car on the road, blasts are growing among all population of patients. I think there's something for us to think about. So definitely keep people on the lookout or enforce electrical cars. That will definitely make a difference in the embryology world.
Thank you. Barry, anything you want to add?
Not really. I think I spoke enough today. I just appreciate all the comments of everyone, and I think there's lots more to talk about.
Right. If I may add something, you know, my own personal experience, the two greatest things, you know, that one can have during his or her career is, you know, the teachers, the mentors, you know, that you can learn from. And, you know, everybody here on this panel, you know, I consider, you know, I'm learning from all of you, you know, like my mentors. And second, the colleagues that you work together with. And, you know, if I look at, you know, my colleagues here in the IVF lab, you know, it's just an absolute honor and just wonderful to work, because they are all absolutely fantastic professionals and also individual persons. So, you know, they are kind of the guarantee that, you know, whatever we do here in our lab, you know, I am quite sure that, you know, we provide the best for our patients. So I thank to all of you, and I thank all of my colleagues. So, and I would like, you know, to this point, thank to all of the 6 panelists, you know, Alison, Maria, Barry, Don, Dean, and Yelena, for your participation and, you know, answering all these questions. I also want to thank to the organizing committee for this initiative, you know, Thomas Elliott, Shaista Sadruddin, Miriam Svetets, Dr. Jacques Cohen, and everyone else who worked, you know, behind the scenes, Alison Bartolucci, Tony Anderson, Liz Neltemat, Dara Berger, and Charlene Aluf, and Jill Palmer also. So there is a tremendous amount of work that goes on behind the scenes to pull this off. So thank you for all of the huge amount of time you spent on this endeavor. I also would like to remind everyone that there is a next upcoming seminar that is the session 18, which is Breakthrough in Placental and Uterine Technologies. And Dr. Liz Neltemat and Dr. Thomas Jensen will host this webinar with Professor Matthew V. Kemp and Professor Mats Brandström. Please get notified that the time for this webinar is going to be different, because typically we do 3 p.m. EDT. At this time it will be 10 a.m. EDT, which is 4 o'clock Central European time. And then just very quickly also that there will be also a special session tomorrow, Wednesday, May 27 at 3 p.m. EDT. And that's gonna be the 56th meeting of the Society for Low Temperature Biology, hosted by Professor Cristiani Amorin. And once again, thank you for all, and see you, and please be safe. Take care. Bye-bye.
Thank you.
Thanks, everyone. Bye-bye.
Bye.